I think we'll get going, and thank you everybody for joining. We have a absolutely packed webinar today. Let me introduce myself. I'm Saul Johnson. Many of you, I think, may know me, but I am the lead partner in the health practice at Genesis Analytics. I'm also the principal investigator on the South-South Learning Network and have been involved with SSLN since its inception. And today we have a very interesting and exciting webinar ahead of us on the whole issue of self-care. And the SSLN is hosting this together with the GPC and UNFPA and WHO, important partners of ours. And as many of you may know, the issue of self-care is becoming more topical, and what the aim of this particular webinar is to help to introduce some of the concepts, introduce some of the guidance, and to give you some concrete examples as well. And as always, to offer the opportunity for people to also engage and ask questions. And I'll tell you a little bit about how best to do that as well. I can imagine that some of you may be saying, hold on a second, is self-care really that new? You know, we've been doing this for ages. From the time then, you know, we're running condom programs, which is a form of self-care, to obviously HIV self-testing. But I think what is changing is that I think we are looking to become more intentional about embedding the concept of self-care all along the client's journey in the HIV prevention journey. You know, starting from the idea of risk identification, all the way through to HIV testing, access to tools and technologies, helping people to stay on using methods that they may wish to use for prevention. So that's what we're really going to be exploring. As I said, it's a very packed program. If we can go onto the agenda, onto the next slide, thank you. You'll see that we've got a briefing from the GPC, from Clemens, who'll be talking about their thinking on self-care. Then we go into some promising practices, and we'll be hearing from a few people. And then Jyoti from UNFPA will be discussing some success criteria. And then Cheryl will talk a little bit about integrating self-care into HIV prevention. And then Tamisai will also be helping to manage the Q&A. And I'll be pushing us all along because I'm very keen that we have time for Q&A. Just a few ground rules, as you know. Feel free to chat in the chat. You'll see that at the bottom of the screen there's a chat function, but there's also a Q&A function which the team will be monitoring, and it's got the little question mark. It says Q&A, and please feel free to drop your questions. And then, because we're not going to have a lot of time, we'll ask the panelists to respond to questions as they come in. But obviously, we can pick that up during the Q&A session. Please note that you can get translation, and so if you click on the little three dots at the bottom right of your screen, you'll see a little menu comes up, and it says interpretation there. And if you click on that, you'll be able to activate a translation into your language of choice. So without any further ado, I'm going to hand over to Clemens to give us the GPC perspective. He has been working on since 2018. It seems like forever, Clemens, with at UNAIDS on HIV prevention. And so really is the ideal person to take us through the next session. So Clemens, over to you.
Thank you so much, Saul. And what I'll be presenting is just a draft brief that we developed in response to requests from GPC partners on enhancing self-care in HIV prevention. And we do this in the context of a new global prevention access framework. Next slide. And this is part of actually the Global AIDS strategy and the new targets that are there for HIV prevention. And in this new context, of course, context of a funding crisis, but also new opportunities, there is a simplification of the framing of prevention intended and also simplification of targets. We will, and we think that it is still possible for countries that are reasonably trying to achieve the impact targets of reducing new HIV infections by 90% compared to 2012 and achieving a 90% utilization target for a combination of prevention options. And that is in a way a little different as it was in the past, because there's now a combination of options that we want to track. And of course, numeric targets like proposed 20 billion global target for people on PrEP by 2030, for example, and proposed here, still not yet endorsed. All of this is still at proposal stage, a 20% domestic financing target for HIV prevention. Next slide. And it is part of a person-centered prevention framework. So what you see here are 4 dimensions that all prevention requires, and also self-care will require. Behavioral or people-centered design and communications dimension, which is about things like knowledge and motivation. We need access platforms, and also for self-care, we need to adjust those. We have, of course, prevention options, which are to varying degrees suitable for self-care. Of course, condoms already being used in self-care, voluntary medical male circumcision as a core service, not being for self-care, of course, but some elements like linkages to self-testing also could be still have self-care dimensions. And then there are policy requirements as well. So this is the new framing in the Global Prevention Access Framework. And as you see, it also provides a map to look at self-care more systematically. Next slide. So in this new framework, there's a couple of transitions here to this person-centered approach with those 4 dimensions. Really looking at the national program approach, so not at specific interventions or just subpopulation programs. And then self-care models expanding is one of the key transitions itself here in this new framework. So that's just for background and context. Next slide. So the table of contents of this self-care brief, it has basically 3 main sections: the rationale, then a section with concepts, evidence, and guidance, including from other areas of health, and then the 4 dimensions for promoting country action following the overall prevention framework. Next slide. So self-care is always, a continuum that requires shared responsibility. There's person-specific, health system, and community elements in that. Next slide. And we have evidence from the broader field of health that self-care can have benefits for health outcomes. There have been reported increases in coverage and access, reducing health disparities, improving quality, health rights and social outcomes, and also reduced cost and more efficient use of resources. Of course, not all of that will apply, and it is not, and that's perhaps important to raise it, it's not just a cost-cutting measure. It really needs to be done with having the different potential outcomes in mind and balance them. Next slide. So there's existing guidance on self-care, and this brief here is not meant to be normative guidance. It's just a programmatic brief and programmatic framework for action. So we build on existing WHO guidelines. There's a WHO overarching guidelines on self-care interventions for health, and then a number of specific guidance areas, including one on sexual reproductive health and rights. And there's other groups like the Self-Care Trailblazers that have elaborated specific component guidance beyond what you see on this slide as well. So we build on the existing evidence reviews and guidance and provide here a programmatic framework. Next slide. So here we look at the 4 dimensions for action at country level, and we have structured it along those 4 dimensions in the global framework. So the first one, the behavioral dimension, we call it here self-management, but it of course also entails the communications and community interventions, the access points for self-care products, and the enabling environment and support for self-care. Now, just a very brief snapshot in my remaining 4 minutes of these 4 areas. The starting point, of course, is the self-management, because for use of any prevention method or option, next slide, we need to have actually an individual who is motivated and informed and chooses to engage in HIV prevention. And the aim, perhaps, of this dimension in terms of programmatic action will be to increase the proportion of people who actually have that kind of motivation and positive behavioral determinants. And we have here adapted a framework for self-management from the Trailblazer group and USAID guidance context, looking at different stages where self-management will be required in terms of, from the, knowledge and awareness to the decision initiation, continuation, and championing. And then the key factors to address that, like self-efficacy, motivation, but also risk perception, as so much in the beginning, are here at the center. And of course, this will look next, if you look at the next slide, vastly different for different populations. And that's why we provided this, this framing here. If we look at self-care, we will clearly realize it is not for everyone, but enabling self-care for those who can practice self-care will free up resources for the maybe more intensive interpersonal outreach, like community outreach or peer education for the most vulnerable population. There is in this whole sphere separate guidance upcoming, and this guidance will be on people-centered design and differentiated approaches to prevention communications, and we'll elaborate more, but it will go into elements like mobile-based intervention examples, like smartphone apps, dating apps, SMS, reminders, web-based interventions, online demand generation. There's already a GPC toolkit, for example, for online demand generation for condoms, could be expanded and has already been applied in a number of countries, including Zambia, Mozambique. Telemedicine is one of the dimensions here as well to enhance. Next slide. And of course, AI-based interventions, and you see here some specific examples. Of course, a lot of action still needed at the global level. Next slide. So then we have here a dimension of prevention self-care tools that is elaborated in much more detail in the guidelines and or in the brief, where you see what kind of actions are needed for specific prevention tools, for example, for expanding non-health sector access, demedicalized access platforms, things like multi-month dispensing, which can apply for PrEP, for example, or PEP dispensing machines, which have been tried, OAT take-home dosages as well. In terms of the access platforms, next slide, which is the third dimension, we actually provide a matrix that could be used for mapping, what are the access points for prevention at the moment for the different populations and products, and how can we adjust that to make it more suitable for self-care. Next slide. And this is my final slide on the last dimension, which is the enabling policy environment for self-care. And there could be a number of regulatory changes. For example, self-testing policy and pre-qualification, regulatory adjustments to simplify PrEP access and demedicalize it, as mentioned before, policy to enable telemedicine, virtual consultations, e-prescriptions, financing and procurement adjustments, and also human rights policy on removing barriers like age or identity-based restrictions or factors that could lead to stigma in the context of self-testing and virtual care. So that's a very quick run through on what is in there, and I'll end here. We have many more examples. That's why I didn't go into detailed examples here. So, thanks.
Thanks so much, Clemens. And I think this is a hugely helpful and timely guidance note from the GPC to help countries consider what is needed as they approach starting to integrate ideas of self-care into their programming. We're going to go straight from the guidance note into some concrete examples. And I'm delighted to introduce Fatia Kiyange from Uganda. Fatia is the Executive Director of the Center for Health, Human Rights and Development, which is an NGO working in Uganda and East Africa around the right to health. And Fatia is going to be talking to us about their experience with self-care in Uganda. So Fatia, I'm very happy to hand over to you.
Thank you so much, Dr. Sol. How many minutes do I have just to check in?
You have 10 minutes.
Okay, so I'll just zoom into the presentation, and I need to acknowledge that this is a country network presentation because we work together with the Ministry of Health, the civil society organizations, the academic institutions. So we are a national self-care group, and I need to mention that at the beginning that this is not just a presentation for my organization, but a Uganda presentation. Next slide, please. So I'll begin with Uganda's vision and journey for self-care. Let's quickly continue, and also to note that I'm presenting this within a broader context. Our vision for self-care is accelerated. We see that integration of self-care into existing healthcare system is a clear way for strengthening primary healthcare management, the multi-sectoral collaboration and synergies, as well as promoting health. And once we do this, we think that we are going to accelerate progress towards UHC. So we see self-care as a single most important measure for accelerating our realization of UHC in the country. Next slide, please. Next slide, please. This is our journey because there are a few minutes. We started by the launch with the launch of the WHO Consolidated Guideline for self-care interventions for health, right in 2019, which we engaged stakeholders. And then we finally decided to formulate a self-care expert group in 2020 and selected the key areas to focus on initially for self-care, and that was majorly on SRHR. The guideline, after being tested in one of the districts in the country, was revised to broaden it to, beyond SRHR, as we'll see. And then we after the testing, the guideline was revised. And as I talk now, let's go to the next slide. The National Guideline on Self-Care was launched last year in October 2024. Next slide, please. Yes, that's the Minister of Health launching the guideline, the photo we passed. This slide is just giving us a summary of what areas are included. So we have family planning, antenatal care, HIV and STIs, post-abortion care, and those that were added after the testing, the test implementation include NCDs, adolescent health, older persons, and persons with disability. I need to note that the key intervention areas include self-awareness, self-testing, and self-management. And for each one of those, there are detailed steps in terms of guidance. Let's go to the next slide, please. Next slide, please. In terms of our achievements, there are many, but we have achieved achievements from in the area of leadership and governance, and the most important one there is the national having a national framework, which is the guideline, but also having a structure in place, the National Self-Care Expert Group that is chaired by the Ministry of Health, working with all other partners. And we also have integrated self-care in many other national policies, including the National Essential Medicines List, FP 2030 costed implementation plan, and so on. In terms of service delivery, again, we have quite a number of achievements, as you can see, but most importantly, even before 2019, Uganda had already started its HIV testing in self-testing in 2015. But in terms of the additions, is that now self-managed ARVs can be given for longer periods, because people living with HIV, persons living with HIV can now do self-management at home and can be given medications for a long time, rather than come many times every month to the facilities. Commodities and supplies, we have estimation of national needs for self-care products and commodities, and also quantification processes that inform what is needed. Also, the country has formed the Commodity Security Action Group, and so on. We can go to the next one. I'm just rushing because of time. Let's go to the next slide, please. Health information, I think the key development there is that we now have a self-care app that is aligned with the National Self-Care Guideline in all the areas in the National Self-Care Guideline. Health financing, we have come up with an investment case that is informed by the SCTG templates, and that is being advanced in the country to and used for advocacy for domestic financing. And also to notice that the national national health budget is providing us with some self-care commodities, but definitely our report that we have stuck out as one of the key challenges. We continue to do budget advocacy because most of the financing currently is coming from our external supporters and donors that include CIF and Hewlett and others. Human resources for health, healthcare workers have been trained, and also the community health workers training is being rolled out, and self-care is being integrated into that to ensure that there are services at the community and family level. Next slide, please. Yes, so we have also documented our self-care journey. As you can see, we have a status report. Let's go to the next one, please. Yes, in terms of achievements here, we actually have documenting services. This is looking at a slide in terms of where we are in service provision. We can see the data, it's not updated yet for 2025, but in terms of HIV self-testing kits, you can see, self-testing, you can see 95% of our district healthcare workers have been trained on HIV self-testing. And also you can see how we have, you can see that we have also distributed, we are distributing HIV self-testing kits, and also the training of community healthcare workers. Let's go to the next slide, please. That is also, we also have national level activities. This was the launching of the National Self-Care app. Let's move, and this was done just last month. Let's move to the next slide, please. Next slide, please. We have oriented, as a country, we've oriented all key stakeholders on self-care, and this is helping us to generate public support. Media is one of those groups that is becoming very important because media is also doing publications on palliative care and doing accurate reporting on the same. Let's go to the next slide, please. Those are just examples. These are members of parliament. We need them, and they've been oriented to self-care to ensure that they are able to appropriate funds for self-care. Let's move. Some of them have actually become very important champions, and that enables us to set the ground for allocation of budget. Those are cultural leaders. Important to get them oriented to self-care because under normal circumstances they provide resistance to self-care approaches, especially when it is focusing on sexual and reproductive health and rights. So it's important to orient them so that they also become advocates and champions, and then to reduce opposition for self-care. Let's go to the next one, please. Next one, please. Okay, I think the next slide is not coming yet. Let's move. Those are religious leaders oriented for the same purpose as cultural and religious leaders. And these have come up with commitments as champions for self-care in the country. Here is the integration of self-care within curriculum for nurses and midwives, championed by the Ministry of Health and the National Self-Care Expert Group. Let's go to the next slide, please. Some of the best practices self-care CMEs and joint support supervision following into in the districts, the inclusion of self-care in triage talks before seeing patients in healthcare facilities, creation of self-care registers, and also self-care going beyond SRHR, because right now the country is undertaking, has embarked on a health integration framework that is advancing integration. And so having self-care be integrated beyond SRHR is giving us an opportunity for scaling up. And then, of course, trained youth on HIV testing and management at the youth-friendly corners and integration in other programs. Next slide, please. Some of the factors contributing.
I'm going to ask you to finish off in the next minute, please.
Okay, so let me just share some of the factors that are contributing to the achievements coming through Uganda. We have strong Ministry of Health leadership that includes high-level champion and a focal person in the Ministry of Health. So the Director General of the Ministry of Health is a champion for self-care, and that is helping to move things in terms of policy, in terms of service provision, and in terms of integration in curriculum. We have also had consistent partner coordination and national self-care expert meetings that are helping to drive the agenda. Joint evidence-based advocacy, including the development of an investment case for self-care and leveraging advocacy opportunities as they arise. Next slide, please. I will stop at the next slide. Mutual collaboration and complementarity between the Ministry of Health and National Self-Care Network, and also all partners that involved in self-care agenda. We have a dashboard that is helping us collect data on service provision, on regulation, policy, and legal frameworks. Also, having professional health associations and councils be involved is helping us to scale up self-care interview provision, as well as information to all healthcare providers. And having champions of self-care within the parliament has also been an important contributor to Uganda's achievements. I think because you gave me a minute, I'll probably stop at that. I had more slides, but I think that's just a feel. I've talked about a bit of these enablers of professional associations, the opportunity for community health workers being trained in the country, the integration in other policies and national strategies. I've done this one. We can quickly go to the next one. Challenges, I think it would be good to hear some of the challenges that are coming through. Stockouts are real for self-care commodities. Self-care is not explicit in the laws. We think that it can be stronger and justifiable as a human right if it's backed by laws, which is an advocacy area. Inadequate domestic financing for self-care. We do not have significant funding for self-care, apart from funding for some of the commodities. inadequate awareness on the test kits and clients not believing in results done by themselves. And that's just a mindset which we will have to change. Most key lessons, I think maybe one of the key lessons is that there is so healthcare workers are not comfortable in the first place, but with continued sensitization and orientation and reorientation, we see a shift when they see the benefits of self-care in practice.
Great, thank
you.
Yes, I think,
yeah. Thank you so much. I'll stop. I think that I'll be able to, I will stop there. I've already talked about some of these opportunities that are coming through. Thank you so much, Dr. Saul.
Thank you so much, Fatia, and apologies for rushing you, but I am very conscious that if we don't, we won't get through all the speakers, and we do have quite a few. I think it's absolutely fantastic to see the amount of work Uganda's done in this area and your achievements. And I wish we had more time to look at your challenges, because I think many countries will face the same challenges as well. So, but hopefully we can come back to some of this in the Q&A as well. I want to move straight on to just to allow Dr. Karen Hatzold to present. I think many of us know Karen, and she's going to be talking to us about the STAR initiative in Southern Africa. So Karen, I'm going to hand straight over to you.
Thank you very much, Saul. And my apologies, I will not show my video because I'm actually at the airport in Johannesburg and catching another flight in between flights, so I will not show my video. Thank you very much for the invitation, and good afternoon. I'm Karen Hatzold. I'm the Global Infectious Disease Lead at PSI. I'm based in South Africa, and my talk is about successes and challenges of introducing and scaling up self-testing in low and middle income country. I'm using the example from STAR. I am the project director for the STAR initiative that was funded by UNITAID between 2015 and 2022. And I continue to work on self-testing and provide more additional evidence for the new use cases together with Cheryl Johnson, who is on this board. Next slide, please. So just quickly recapitulating on obviously on self-care and the self-care agenda to which self-testing belongs is, we know just that at least half of the world's population has no access to essential health services, and to achieve universal health coverage, we must complement traditional provider to client model with self-testing and with self-care model. So self-care interventions are really amongst the most promising and what's really exciting approaches to improve health and well-being, both actually from the health systems perspective, because they're reducing costs and also reducing the burden on the healthcare providers, and also for the users of these interventions, as they are very client-centered. They can increase choice and autonomy when they are accessible, acceptable, and affordable. And this is what we've also tried to establish with the STAR initiative on self-testing, making these services accessible, acceptable, and affordable. They also represent a significant push towards greater self-determination, self-efficacy, autonomy, and engagement in health for self-carers and caregivers. So self-care and self-testing interventions have also played a critical role, as you all remember, during the COVID-19 pandemic, because the sustained health services with self-care and self-testing actually increased during this period of time as well. So self-testing, as we are framing it here, and self-sampling, as you see in the slide, become increasingly important to fill the diagnostic gap for many infectious diseases, not only HIV. We worked with STAR on COVID-19 and also on hepatitis C. You see that huge testing gap that we have also with hepatitis C, nothing to compare what we have with HIV, where many people, 35% of people are living with or with chronic hepatitis C infection know their status. So a huge testing gap. And I will speak a little bit about our work on hepatitis C self-testing as well. Next slide. So what did we do in STAR? So this is showing you all the countries in which STAR self-testing was implemented. I'm calling it STAR self-testing because initially it was the self-testing, HIV self-testing Africa project. So it was focused on HIV, and that was our prototype or the proof of concept for HIV self-testing. Moved then to, as I said already, hepatitis C self-testing, providing the evidence for that as well, which resulted in pre-qualification of the first hepatitis C self-test kit. And then also during COVID-19, we tested 6 COVID-19 self-test kits as well, and provided the evidence for their acceptability, feasibility, effectiveness, and cost effectiveness. Next slide. So the agenda underlying all these efforts under the STAR, so the STAR was implemented altogether in about 15 countries around the globe. In 3 phases. When we started in 2015, we didn't have any policy, we didn't have WHO guidance on self-testing, we didn't have a product. So we started really from the start to provide this proof of concept for self-testing that informed obviously policy guidance and then also the scale up. So through the different phases of STAR. Another aspect of the STAR initiative Unity funded was to develop a market for HIV self-testing and for self-testing itself, with product introduction, providing the evidence, but also the volumes that were required for doing any market shaping interventions, and also directly involved with supply side interventions as well, that reduced the price for the self-test during that period of time. And I'll show you that on my next slides. Next slide. A big part of our work was to provide evidence for the different use cases in which self-testing could be used to increase uptake of testing and also linkage into care. Initially, when we started, the major focus on self-testing was to identify those people who had not yet tested for HIV and then to link them into care and treatment. And the populations that we focused on in the different epidemiological backgrounds were obviously men, especially in Southern and Eastern Africa, are much less likely to test or to know their status than women. We also focused on our interventions on key populations because these were also populations that were not tested. There was a huge testing gap as well amongst key populations. Young people, adolescent girls and young women are also much less likely to know their HIV status. So these were the major target populations. Obviously, there are other populations as well included in there. And then we developed, based on the different target populations, our approaches and the use cases for self-testing. In the middle, as you see, the different approaches have evolved over time. As we go along, we started with community-based self-testing out of facilities, and moved and optimized really our mix of HIV self-testing approaches to reach these priority populations and also the different use cases. So HIV self-testing initially to identify those who had not tested, to fill that testing gap and to link them into care and treatment. But much newer now, also facility-based self-test use cases that could increase efficiency of testing and increase coverage at public sector healthcare facilities, reduce the burden on the healthcare providers. So another use case for self-testing. Also linking people who tested negative. Again, the aspect of prevention is extremely important. Clemens mentioned it already before, linking people who self-tested into VMMC. And also obviously now all the evidence on using self-testing as well for initiation and continuation of PrEP, including hopefully soon some more evidence on that we can reason also with long-acting PrEP. What was very important as well in the consideration is also my next slide.
Karen, sorry to interrupt you, but the interpreters are finding it a bit hard to follow you.
Oh, okay.
So if you could slow down, I know you've got a lot to cover, but if you can slow down a little bit.
I will do. Thank you so much. Sorry, that is my enthusiasm. Je peux aussi parler français si vous voulez. Je parle portugais. What I will calm down a little bit. What we also need to consider with these approaches, and my next slide speaks to this as well, that we need obviously tools that enable people to know how to test themselves, and especially in the beginning, this was very important. Having additional tools available so that people could understand how the self-test was used, In addition to the instructions for use, we developed user guides. We also developed digital tools that people could be using to get through the testing process. And then also helps and support functions and interventions that linked people into care or into prevention. Next slide, and that is the picture in the next slide. And I'm happy that Shout It Out is here as well. We'll be speaking about that chatbot as well. So we developed these digital tools as well to enhance the self-testing experience, and then also to help people to link into post-test services. So we developed a chatbot. Many chatbots were actually developed in the different countries that helped people to go through this process. People could access these through social media channels as entry point, and then were prompted to also going through a risk assessment as well, and then helping them step by step to go through the testing process. People could then disclose their status or send in their test result so that the test result could be interpreted, and then got also vouchers for presenting at healthcare facilities based on their status for prevention as well as for treatment. These tools were quite helpful to manage to support people. They also were quite helpful actually to get some M&E and data, because at each step of this cascade, data was collected as well, obviously all voluntarily. So that we had also some ideas about the people that were using these apps and whom we were reaching. Next slide. Just a quick overview of summarizing the evidence that we gathered through the multiple years of STAR implementation. And I just show you a little bit of a sample here for all the journals that were and the supplements that we released and provided. So a lot of evidence that then fed into the WHO guidance. I'm showing this on the next slide, as well as providing a lot of evidence as well for optimization and for advocacy for self-testing. So we could really demonstrate that self-testing increases the uptake of testing. Also that the proportion initially, as I said, we wanted to find those people who had not tested before and that did not know about their diagnosis. So we could establish that with self-testing, we enabled more people to know about their status. But because we're able to test more people, it was actually greater than facility-based testing or community-based testing. We also have evidence that linkage into care was comparable to facility-based testing, and that linkage to confirmative testing and ERT post-HIV self-testing is really relatively high. And that was a major concern initially when this was started, particularly with assisted self-testing, meaning that people got instructions from the healthcare providers on how to conduct the test. We also could prove with multiple costing and cost-effectiveness studies that HIV self-testing is cost-effective, and also that the initial concerns about social harms were also not provided or fulfilled. Next slide. So this body of evidence was very important to shift policy, not only at global level through the development of the WHO guidance on self-testing and different iterations and operational guidance on self-testing that were then published, but it also showed here on this picture between 2014 and 2024, we increased the number of people, countries with policies in place from 3 initial countries to 108 countries, I think in 2024. I don't have the latest statistics with HIV self-testing policies in place. Next slide. Yeah, again, obviously through the global guidance and normative guidance that then informed this, we've also differentiated and simplified exposure prophylaxis for HIV prevention that included self-testing. All these guidelines were based on the evidence that were gathered. Next slide. A little bit about market shaping, and that's probably a bit of a more challenging area with the self-testing that we established. So the market development has been relatively slow. As you remember, OraQuick, which was the first prototype for self-testing, still the only oral fluid test that has pre-qualifications today, was FDA approved already in 2012, and then only through the process that we put in place and supported as well in 2017, only received WHO pre-qualification. At that time, the cost for the OraSure test was $3.5. So the buy-in, buy-down by the Bill and Melinda Gates Foundation in 2017, this price, as far as a volume guarantee, could be reduced to $2. And that would another benchmark for other self-test kits that came on the market. There were then several blood-based products that came on the market initially, so the Biolyticals Insti test, then Myelin, Abbott, and so on. We are currently at a price, a cost, works cost for an HIV self-test and blood-based test at around $1. So they want for via the net access and market shaping or market access vehicle reduction of the price to about $1. And that is since 2022 when this was launched. We have one additional test now. We have 7 pre-qualified HIV self-test kits. That is the urine test, urine-based test from Wang Tai in China. So we have now 7 pre-qualified tests. Why I'm seeing this was a bit challenging because we had initially only the oral fluid test and everything was about the oral fluid test, and even in terms of how it is depicted of how you do a self-test with the swiping the gums. The blood-based tests are self-test. It took much longer time to be in the market. The example in Uganda that really was very spearheading this of allowing several self-test kits to become on the market, including a couple of the blood-based tests, was really good. But we did not see that uptick in many of the countries. And even today, countries still want to do validation studies and feasibility studies and acceptability studies of blood-based self-test kits, which actually is not really required because we have WHO pre-qualification for this. Just wanted to mention that as a challenge because obviously the more test kits we have on the market, the further we can reduce the price, the higher we have not the dependence on the monopoly for the self-test, and the more we have also choices for people to use self-test kits. So the more test kits are pre-qualified or registered at country level, better the choices and the higher the volumes. Next slide.
Karen, I'm going to have to ask you to end off in the next minute or so.
I will do so. Yeah, I'm nearly done. I just wanted to quickly show you here that the experience that we gained with HIV self-testing was then also used for hepatitis C self-testing, using the same approaches, establishing the acceptability, feasibility, and costs and cost effectiveness. We did this in 5 countries across Asia with different populations and also different epidemiological backgrounds. And again, next slide. This time we use both oral fluid. Next time, the next slide, please. 2 different test kits. The Ora Quick test, which is the one that got pre-qualified by WHO. And then we used also a blood-based test. And in the research that we did in these different countries, there was no specific preference for oral or blood-based tests. So both really were highly acceptable by the populations that we used them on. Next slide. So again, I think a lot of top-level results from these studies as well that were conducted in the different countries with giving us answers who is reached. What is the positivity rate, how people are linked into care. As you know, we have for hepatitis C the cure, which is the DAAs, and then in terms of also how this influenced the market. Next slide. This also resulted in the pre-qualification of the first self-test for hepatitis C virus in 2024. We had in 2022, based on the HIV self-testing guidance and the evidence already, there was already WHO guidance for hepatitis C self-testing. Next slide. So the lessons learned from that, again, it took us a long time to get, it took us 10 years to get HIV self-testing guidelines and pre-qualification. It took us much less time than with hepatitis C. So the more we gained evidence, the more we gained practice with this, the less time was needed. So 3 years for hepatitis C self-testing, 2 years for COVID-19 self-testing, and then another 2 years for syphilis self-testing. So as we are gaining evidence, as we are getting practice, the less time we will be losing. for getting additional test kits, self-test kits on the market. Again, we're speaking now a lot about multiplex testing and diagnostics as well as self-tests. So that's, I think, the new area. Next slide, my last slide. Self-testing really bridges the testing gap. We need to increase availability and option and choices with the blood-based products, potentially which are urine products. And self-tested are in the pipeline for hepatitis C and B, and also for multiplex self-test kits. We need to optimize further optimize the use cases for self-testing, facilitating linkage in care and treatment and prevention, especially with use of self-testing with PrEP, which is, I think, the new thing that we should be really a step for, which we need a bit more evidence for the use of self-testing with a long-acting PrEP. And digital tools, and that I think transitions quite well into the next presentation. Digital tools and AI technologies for self-testing are very useful and could be leveraged. Thank you so much for your attention. My last slide is just my contact details. Thank you so much.
Thanks so much, Karen, and thank you for joining us from the airport. I think this is a great overview of all the fantastic work that you've done on firstly HIV self-testing, and then looking at hepatitis C self-testing as well. So well done and congratulations. I know it's a huge amount to cover, but lots of really good ideas in there. We're going to go straight on to the next presentation. That's Dr. Ntombifikile Mtshali. And Dr. Mtshali is going to be talking about, and she's the Chief Executive Officer of Shout It Now, which really focuses on community-based health services. So, and please, can I ask the panelists just to check in the Q&A or the chats if there are any particular questions directed at you, if you wouldn't mind addressing them. But now I'm going to hand straight over to Ntombifikile. Thank you.
Thank you, Saul. The rush against time, but having to be slow enough for the interpreter. We're going to try our best. Thank you so much. Good afternoon, everyone, and thank you for the host and the colleagues from SSLN and GPC and UNFPA. So, as already mentioned by Saul, I am from South Africa, for organization focusing on young people's health and well-being. It is a pleasure for me to share lessons from our self-care from anywhere journey pilot, which uses AI and to be able to expand HIV prevention care and prevention and care for young people. Next slide, please. I'm going to try and speak in bullet points. I have no conflicts with this to declare. Next slide. I wanted to paint a picture around the South African context. I will not dwell too much on this slide, but just to say that even though there is progress that has been made, there are significant stubborn gaps that we are experiencing, particularly around populations, and I won't rehash what Karen and other speakers have already said. We're still seeing new incidents of, seeing new infections in those population groups. According to UNAIDS 2022, incidence was at 1.3 million. Particular populations include key pops, but as well as adolescent girls and young women. So we'll focus on adolescents and young people in this presentation, but if in that space, you can use any other population. But we also know that young people still face stigma, the waiting times, and also fear of judgment. So we also know that traditional systems do miss them. So how do we meet the moment? Next slide. In the moment, particularly, I'm thinking it's actually very well timed in terms of how do we deliver or rethink how we deliver care with diminishing funding, but also there's a need for us to reach this particular stubborn population. So we're being asked to do more with less. So then we have to rethink, especially moving away from that facility-based model to patient-centered approaches, as already been covered by Clemens. And this is where we see an opportunity for we saw an opportunity for AI to be able to, understanding that it's not a cure for everything, but when used responsibly, it can definitely amplify human care because it offers real-time guidance, help to interpret HIV self-tests and other tests, and also able to automate follow-up reminders at a scale. And that's how the idea of self-care from anywhere actually started. So using AI as a partner, not a replacement in the care delivery. Next slide. So let me introduce you to Amy, who is our digital health companion powered by AI. Amy is a play on AI and me. This was the, what's the word? It was the young people that we co-designed with came up with this word and the name for the tool. So it's quite exciting that we're able to actually also embed them in that co-design phase. So what it does is that it combines large language models, computer visions, and as well as predictive analytics to support self-care, self-testing, PrEP guidance, and mental health education. But it can also span across various topics, as we've been able to find in our pilot, that young people reach out for all sorts of topics, including sexual reproductive health, mental health, as well as support with the study, just being able to navigate the transition period that they're obviously going through in their bodies, and just being able to provide credible information. So the beauty about Amy is that it communicates in local languages, and we call it slang, but I don't think it's slang because it's a language that young people use, but it is through WhatsApp. It's private, it's stigma-free, and it's accessible at any time, 24/7. And it also allows us to be able to meet the young people where they are. So the basic tenet of what was very important for us as we were co-designing this was that we need to be able to have a tool that simulates empathy and make conversations feel safe as well as supportive for the target population, which is what adolescents and young women in South Africa. Next slide. So this slide really is just talking about how AI promotes timely linkage to care by confidence and decision-making. I want to call a study that was done by Audrey and partners, who are our tech partners in this self-care from anywhere tool. The results come from a study called Improving Confidence and Trust in Private Sector Telemedicine for HIV PrEP, as well as delivery with AI. We saw that in this study, or in just what are you seeing on the left, there's a faint line there that sometimes with the human eye, it can be missed. So both the client and the nurse did not see that particular faint line. However, the computer vision was able to pick up that line and also offer a trigger to the client as a nudge to be able to connect them to a healthcare professional, but also in the back end, the nurses are also able to view the uploaded messages and then be able to see the client's interpretation as well as the AI interpretation. So this use of this rich data, they could then make their own determination of the result. So additional checks and balances obviously need to be in place where the AI and the nurse might have disagreed. So conversations. Without going into too much of the work of the talk over there, just to talk about that, there was during the program, we had a 30% improvement in the nurse's ability to identify positives where there was an AI interpretation alongside it. So demonstrating that AI can be used as a diagnostic partner, empowering both the healthcare workers as well as the clients, and ensuring that they have trust in their decision. So what we are seeing here is that the AI detected up to 80% with 80% accuracy versus what the nurse also was able to see. But also what's very important is that then there is a linkage to care. So you get a trigger if there is something that is flagged on that nurse and the clinical portal. The nurses are able to see the summaries as I've already mentioned, but they can also start providing some nudges, and they can be and the young people can then be linked to care that they need, whether it's PrEP, or even ART, which then allows them to be able to start treatment sooner or prevention methods a little more sooner. I'm going to probably emphasize this throughout the conversation around ensuring that there is a human in the loop, because it's not to replace healthcare workers, it's to support them in terms of making sure that they can triage, well, the AI tool can triage, and also ensuring that it becomes a diagnostic tool or partner for safer and faster decision making. Next slide. The numbers alone don't tell the full story. So the essence of this next slide, and I think just skip to this one, to the next slide, because I can tell you about all the figures, and I'll put some on the chat because there's quite a few of them. But imagine a young 22-year-old woman who's worried about their partner, about their partner's fidelity. And they are now sitting late at night and they send a message to Amy that says, please, I'm worried about my partner is cheating. The tool then gives them the information in a non-judgmental way and helps them guide them to self-testing, but also towards PrEP and other prevention methods so that they can be supported. And what we are finding as feedback is that this is really, at SHART, we really pride ourselves with being able to reach young people effectively, more effectively, especially in the community, in a safer environment, et cetera, et cetera. But we are able to do better. What we're seeing is that AI is actually even allowing young people to be more open without judging them, and as well as then linking them up to the support that they may need. The next slide is perhaps how do you access Amy? So how do young people access Amy? There is a WhatsApp chatbot, like I've already mentioned. There is a clinical portal, which is what you are seeing on the top right corner there. But Amy uses a natural language processing to be able to answer questions in a local language, in a context-specific language. We've said slang, but again, like I say, it's the language of the young people, or language that the target market would be able to understand. Providing the 24/7 support, which is anonymous, as well as very safe, non-stigmatizing treatment literacy information. And what is also very important is that it can then be used to trigger automated, respectful follow-up nudges to be able to schedule appointment reminders, and also ensure that we can connect these young people to peer supporters or clinicians via the secure platform. The content is tailored, like I've already mentioned, and this is really meeting young people where they are at the time that is convenient to them, as also on the platforms that are important for them. Next slide, please. So what are the lessons that we've learned? Probably echoing some conversations that have already been touched on today. Target population-centered code design, very, very important. Trust and privacy, and the assurance that these conversations are private and that the data is not going somewhere else. They do drive uptake because they are able to engage more openly, knowing that their data is not going to be shared maybe with their parents or shared maybe with other people who might, who might not be supportive of what conversations they may be having. Lastly, it's the human in the loop, which I've already mentioned. Complementary, AI is a complementary tool, part of the arsenal in the toolkit, but it's not a replacement for healthcare workers. Next slide, please. So perhaps what would be important also is to mention where we are going and what's next with this tool, which is a primary healthcare and lifestyle companion for HIV and TB support is what we are finding. So just for our specific context, we are continuing in South Africa as shouted now for adolescent girls and young women. We are ensuring that young people also, we are plugging this tool into a National Department of Health adolescent care and young people tool, which is called Self-Up. At the end of November. We're also using like PSI was already mentioned, Karen. We're working with Coaching Below, the team that's looking after men's health, especially in HIV and TB care. Also some examples, and I did see someone from Shesha in the chat earlier. This app, it's called Vimbai. In Zimbabwe, it's supporting female sex workers. So while each model can look different, they all share one thing. It is a trusted person-led engagement that bridges the clinic as well as the community. So where are we seeing opportunities here? Being able to support Lenacapavir rollout, especially connecting individuals who need it the most, not just trying to reach everybody, but also what we've already spoken about, the multi-month drug dispensing plans, and ensuring that there's a flow that supports those clients on those particular plan that is helpful. I can see you, Saul. So this is literally my next 2 more slides. So next slide, please. Just talking about the key enablers, and really, I'm also just going to summarize these, the 4 key lessons. I'm going to group them into systems as well as people. So on the system side, we need to build secure, interoperable data infrastructure and develop strong ethical frameworks for consent and fairness around data, et cetera, because that becomes a very important consideration. In people, when it comes to people, we need to invest in partnerships across tech, policy, community, and also build capacity for healthcare workers to be able to interpret the insights that are being generated based on AI. Last slide. Again, my last slide has disappeared, but my last comments are just that this pilot has shown real promise. Young people are engaging, they are learning, and they are linking up to care. We are ready to scale, but we can't do it alone. So it's always very important to have partners in terms of the work that we do between innovators, policymakers, funders, researchers, and academic partners as well, to expand that ethical AI for good solution to make those self-care tools accessible for everyone. The last slide was just acknowledgement to our partners, including ODERE, NDOH, National Department of Health in South Africa, our funders, as well as our academic partners, and of course, our donors. I did not include my context details on the slide, but I'll just pop them into the chat, and this is where I end. Thank you very much.
Thanks so much, and Ntombifikile, I'm sorry, this is the burden of being the facilitator, is that all the panelists hate you because you cut them off all the time. But well done. Those were absolutely 3 fantastic presentations, I have to say, looking at a country level and then at self-testing, and then this last one at a digital tool and AI-enabled chatbots. Really so fantastic to see how these various initiatives are being developed and implemented with real world results. So well done to all the panelists. And I hope that's inspiring for everybody. We're going to go straight on to the next presentation. And that presentation is going to be by Jyoti Tiwari. Jyoti is the Regional Health Systems Advisor for Eastern Southern Africa at UNFPA, and Jyoti is going to be talking about success criteria for taking self-care to scale. So Jyoti, can I hand over to you?
Thanks, Saul, and thank you so much for each one of you for taking time out for this conversation. I see around 93 participants in this conversation, so really grateful. So very briefly, in partnership with the Swiss Tropical Institute, UNFPA Eastern Southern Africa office, we looked at around 90 SRH self-care interventions in Africa. In particular, we were interested why some of these interventions are operating at scale. They were able to attain scale, while others are struggling a bit. So the main idea was very simple. Are there any common factor or features of self-care interventions which are being able to attain scale. So I have around 10 slides, but looking at the earlier conversation, just limit myself to a couple of them so that we have enough time to have a conversation about it. So let's keep and straight go to the slide number 8, perhaps. This all been discussed and then we know about these things. So can you, move down, please? Yeah. Yeah, down again. Okay, so no, up, sorry. Yeah, one up. One, okay, one more. Can you go down? Sorry about this. One more down. Okay, I'll leave it there. Okay, so yeah, probably a slide is missing there. So as I said, we looked at 90 odd self-care interventions, of which around 60% were HIV centric, and then they included all the three presentation or interventions which were presented. So and then we found perhaps these 5 features which we need to pay attention to. The first thing we learned, regular reinforcement is important for the success of self-care. And nothing new. We have been talking about it. Many presenters before me presented, either through phone calls or through digital channels or through providers. It looks like regular, frequent follow-ups improve engagement and consistency in the self-care practices. Similarly, many of our speakers, they spoke about digital solutions and their importance for attaining scale. Absolutely no doubt about it. But let's make the distinction that digital solutions by themselves are not self-care. Self-care includes self-awareness, self-testing, and self-management. And then digital solutions are a critical part of it for attaining scale. But it looks like the interventions which has gone to scale, if the digital solutions are implemented in tandem with other options such as support person and particularly self-care from anywhere colleague, they talk about the support person and referral mechanism, then it's even better. The scale becomes bigger. Similarly, which was strange finding, it looks like when it comes to young people in particular, the self-care interventions benefit hugely by having a support person. And that support person could be a more experienced peer, a counselor, a community health worker. In many cases, can be also parents in case of HIV. However, the selection of the support person, while selecting the support person, one need to take into account the confidentiality concerns around the condition. But so that's something to keep in mind. Still, perhaps, particularly young people, for their own confidence to try out self-care, particularly self-testing and self-management, a in-person support person is important. Many people spoke about it. The other thing, because of the biggest challenges perhaps to attain scale was access to products, whether for self-screening or self-management. Still, we need to do a lot of work how to make these products available. It requires work at the regulatory level, it requires work at the financing level, it requires work at the delivery level. And therefore, designing and delivering self-care interventions requires a participatory approach, and it does require a system thinking, looking at what specific interventions, in case of Uganda, they showed it, needs to be done at the policy, legal, regulatory, financing, and then supply chain level. So that's kind of, and one of the other things which came up, which is hidden in there, in many cases, perhaps the provider themselves, might act as a limiting factor for many self-care interventions. So therefore, providers' value clarification also is equally important. So these are the kind of 5 things when you are designing any self-care intervention, probably we will benefit hugely if we keep them in mind while we are designing it. As I said, it looked at 90-odd interventions, and all of the interventions which are presented before me were part of this exercise. I was just checking the report, but we will share the report with the rest of the team and then the group. And also on the basis of this particular work, we also develop kind of 3 support tools. Can I go to the next slide? The next one, and I will end there. Okay, so it's not there. Maybe this is an old presentation which is there. So those, and then out of the 3 support tools, 2 support tools are around integrating family planning and HIV, some practical support tool, learning from the experiences particularly from these countries. And the other support tool also, how do we optimize different sources of family planning products to optimize self-care interventions. So my submission here, Clemens, probably not only we will share the report of this exercise, but also the draft support tools, and then probably there might be some opportunities that they may inform the guidance note which you are providing. So let me stop there with those 5 key success criteria which we thought is really, really critical in Africa for taking self-care to scale. So back to you, Sol. I hope I saved you some time.
Jyoti, thank you so much, and that's well done, because our next speaker is Cheryl Johnson, and Cheryl's got a hard stop at past. And Cheryl, for the people who don't know, and I think many of you do, is the technical officer at WHO, and Cheryl's going to be talking to us about integrating self-care into HIV prevention. Cheryl, so I'm going to hand straight over to you.
Excellent. Well, we can go to the next slide, and I'm so pleased to be with you today and talk a little bit about self-care. It's something I'm very passionate about, and I'm in good company. So we can go to the next. This has already been, I think, summarized by others about the kind of high impact HIV prevention tools that we have. But I think it is really important to always center our discussions around self-care about what we really want to achieve and what our goals are. So we know in HIV prevention, we still have 1.3 million new infections. We have a long way to go to achieve our goals, including those that were articulated at the top of this webinar. And we know these gaps are actually growing, and we're predicting even more new HIV infections due to kind of gaps in funding and changes in service delivery. So this is, I think, the context that self-care really needs to respond to. You can go to the next. So why is self-care relevant for HIV prevention? I think it's really said well by the Self-Care Federation that talks about better choice, better care, and better value. So it is more accessible and acceptable. We've seen constant evidence, and I'll share some experience from self-testing, but across the board, self-care is something that can enhance targeting and demand creation. It's something that can really increase uptake and effective use. And it really puts people first to help them be in charge to optimize their service delivery, kind of the needs they have and their unique health journeys and goals. It's something where it's very client-centered, and that I think is so important to hinge on, as well as the benefits it can have. So we have some estimates now that show that self-care models could save us really big in terms of cost containment for the future, and also fill that health system gap and reduce client opportunity costs. So it's not just about saving things for the health system. It really is about reducing some of the transactional costs of going to the clinic and having a lack of flexibility with the health system that we're traditionally used to. We can go to the next. So I know this is a lot of content, but on the far side, I think it's important to talk about the dynamic nature of self-care so we don't get boxed into one idea. It's really something where we think there's a continuum. It's not zero sum. The self-care continuum can be things that are purely full self, individually controlled at all times, or largely individually controlled. So those could be like daily choices, condoms, maybe more knowledge and awareness. And then there are things that might be more self-directed or shared between community or a lay worker with some kind of self-care. And then there's also going to be things that, regardless of a self-care paradigm, they might be largely clinical or specialized. And I think it's important in the prevention conversation to embrace all of these, that self-care has a role in each of these buckets, and that there may be small adjustments that actually make big gains in terms of increasing access, enhancing patient experiences, and also reducing provider workload and making things more manageable for them. And then there's also the dynamic of where does self-care start and end? And I think this nice pyramid that's been around for a while really shows that self-care can really be at the very bottom, but there's a continuum of how it fits in with informal community care, pharmacies, primary care, community services, and it can be incorporated even in facilities. So a good example of that is the facility-based HIV self-testing, that while that's a facility, there's still a self-care element kind of coming in to the way the care is delivered. So we can go to the next. So I wanted just to apply a few lessons from self-testing here. And then this kind of slide, what you're seeing is the key evidence shows, self-testing is safe and accurate, acceptable, feasible, flexible. We've seen across the board how it increases access, uptake, and frequency of testing, including those who are at higher risk and who are unreached or underserved. We've seen the benefits in increasing case finding, linking people to treatment. We've not seen anything on increased social harm or clinical harm, and it's empowering, something that I think is really important to the self-care conversation. We have evidence it does fill kind of gaps in human resources, and we see it as an effective enabler of HIV prevention, including PEP and PrEP, as well as increased affordability. So this is what really drove our recommendations. And I highlight this because at the time, when we made these guidelines at different time points, HIV self-testing was an early adopter, and this evidence is very relevant to all the applications of self-care. So what we've learned here, I think we should really be extracting and applying as much as possible to the new paradigm of self-care and prevention across different products and different use cases. So we can go to the next. So here's just an example of how self-testing can be integrated into prevention by focusing on what we have in our traditional health system, and then I'll show an example after this of what the reality really is of why self-care is critical. So I think with PrEP, we often have looked at this journey of PrEP delivery as something very linear, that people's lives are going to be simple and their PrEP journeys will be simple, and testing and delivery can be 100% accurate, 100% adherence. People will be on PrEP for forever as long as they need, and it live happily ever after. And I think in reality, if you go to the next slide, what we've seen across our real world implementation is that traditional facility model just wasn't working for a lot of people. So for many people, the reality was they couldn't come to the clinic that regularly. They were splitting doses and pills. They were taking kind of long breaks and needing to restart at different times. There were PrEP holds happening because the tests and the delivery wasn't always as readily available as one would have hoped. And, people's seasons of risk were changing more regularly than I think anticipated in what was controlled in like a clinical trial. So this is a really good kind of map that I feel like is applicable to other prevention spaces to really think about the patient pathway and where self-care could then fit in based on the problem of what can we do to really enhance things. So if we go to the next slide, what you see here is we do have guidance now on self-testing to support PrEP delivery. And we've covered a range of things that could increase someone's experience and really give them better prevention access. So one, self-testing can be used for PrEP demand creation. We see in Nepal that here with a peer, this is where it's helping enroll people and getting people started and engaged in PrEP that would otherwise be missed. Self-testing can be used for PrEP initiation. And here in this one example from Thailand, we hear directly from a client that this helped them really initiate PrEP, and it was convenient, and they kind of regained their control, and they were really finding this to be much more convenient and simpler than their previous PrEP delivery model. In Brazil, we have PrEP reinitiation for people who might have stopped and then needed to start. And again, finding this to be much more convenient with reductions in their time spent at health facilities, making it easier for them to stay engaged in PrEP. And then self-testing for PrEP continuation here in Eswatini, where we hear that, an individual talked about this as a perfect arrangement for her, that after a self-test that was negative, she was able to talk to a nurse and get PrEP, but she felt confident, and she even took some tests to support her partners. And I think that that's a really great example of how self-care can even start with just you as an individual, but instantly can engage the community simultaneously. We can go to the next. So with all of this, is just to say things have changed. Karen showed this slide, but I think it's something to reflect on is while we might be talking about self-care for HIV prevention, and we don't have maybe as much clarity on all the uptake of those recommendations yet, a lot has been done and a lot is still left to be done. And I'd love to look at this slide for HIV prevention to see all the self-care commodities, policies get to go from this red map to a green map. So that is my goal for us to think through, but we can go to the next. And then we have some lessons that I feel like are really applicable here across from what we've learned from self-testing that really comes down to simplification and embracing some of the different choices and options you have in the prevention space. So one, we really see this as something that increases acceptability, feasibility, access, and uptake. And in all the implementation models, we should be really thinking about the benefits of how we can simplify things and how we can also increase choices at the same time in that right balance. The affordability and cost savings is super critical. Everyone's talking about it all the time. So important to continue to really look at where those strategic wins are, where self-care can help with affordability, both for the health system and for the client. And then I think one of the things we also have learned is it's really easy to end up with lots of different self-care simplification. We can make simple things really complicated in the policy space or in the monitoring space. And so trying to then really pare that down to what is a simple, coherent policy, regulatory, and monitoring framework that supports all the things you need. So task sharing, community engagement, streamlined processes, leveraging the regulation. We can go to the next. And we've got some lessons from our, I think, implementation tool from a few years ago that I think provide some insights. So I think check this out. Doing situational analyses like that map of the patient pathway, but also for the broader health system, I think is very important to plan for self-care, as well as the review of trying to really collapse a lot of those separate policies into something much more coherent, and having this kind of plan of how you might implement and start distribution and provide the correct resources, trainings, messages for providers, users, and communities, along with the quality assurance system. And go to the next. And on the quality assurance system, I think this is something that gets left out sometimes, that we have a lot of learnings from self-testing that are applicable about we want to have, if something goes wrong, this is what providers and people are often concerned about with self-care. Is this abandonment? Are we marginalizing or hurting clients that are very vulnerable with self-care? How do we know this is the right choice? And I think we've gone through a lot of that in HIV self-testing that we think, I think can really be bolstered further, thought through more with the prevention paradigm of how can we use some of the tools that are out there already from self-testing and adapt them more for prevention more broadly, situate them in decentralized services like community health systems, like liaison officers, more targeted virtual follow-up, and thinking about how we can maybe do blitzes or short-term tracking for an implementation phase to really help optimize a self-care model, and then working closely with the community for a lighter touch, longer term follow-up. We can go to the next. This is just a little checklist I put together that I thought could be nice to say, if you're thinking about self-care for HIV prevention, what do you need to really make sure you're talking about? Policy, service delivery, commodities, community, financing. And just a few thoughts to say, how do you just go from having a webinar about self-care for HIV prevention to doing it? And here's your list. And we'd love to hear more about what you're doing and how we can support it, because I think this is the future we all see. And it's something we really need, I think, collective buy-in and support for. And go to the next. So in conclusion, self-care is not new, but there are new opportunities. It's really important to enable prevention that is on people's terms and use models that are built around people's lives, not facilities. We really learned that in that PrEP example I shared, but that's the backbone that I think we really need to apply here. Self-care is really about access, simplification, and person-centered delivery. Don't get too hung up on which technology. Is it a self-test? Is it a self-injectable? Maybe, maybe not. But self-care approaches are still really relevant. It's not zero-sum. There is a continuum. So even the simple shifts in that continuum could lead to really big gains in access, simplification, reduced costs, reduced workload, streamlining, and open up new things we didn't see before as possible. And lastly, HIV prevention, options and choices. I think you guys have been such leaders in the prevention space about giving people choice. Embrace that as a key strength for self-care. So my call to you is it's time to kind of enable, equip, educate, engage, ensure, and evolve our HIV prevention so we can be the new leaders in self-care. So on that note, I'll say thank you. Go to the last slide, and I've got my email. Reach out to me if you've got any questions. Would love to brainstorm or collaborate with anybody.
Cheryl, thank you so much. I'm afraid we have run out of time, and we've run a few minutes over, and apologies, colleagues, for that. I think Cheryl really summed up better than I could. Just to say, we know in public health there are no magic bullets, but self-care does present us with new opportunities, but there are things we have to get right, and I think Cheryl and the other speakers presented lots of thoughts on how to do this. Colleagues, thank you so much for joining, taking the time. Please, Madonna has posted the links in the chat about where you can find all the materials, or you can reach out to her directly. She's put her email address. Thank you so much to the panelists and the organizers and the interpreters, and to the SSLN, of course. And we will see you next time. Thank you, everybody.